The views and opinions expressed on Coffee and Compatibility are those of the podcast host and do not necessarily reflect the official policy or position of ASHI.
Hey everyone, welcome to another episode of Coffee and Compatibility. I am Eric Weimer, and with me, as always, is the lovely Dr. Kelly Hitchman.
It makes me
How are you?
blush every time.
And Mr. Jeremy Sherrill, how are you?
I'm good. He didn't call me lovely.
You are lovely.
That's devastating.
I'll tell you that.
Maybe the next intro.
Maybe it was just awkward, but I can tell you that. You look fantastic today, Jeremy.
Thank you so much. Yeah.
You
I'm
look
wearing new pants, so I'm sure that's
He said he's
I
wearing
couldn't
new
tell.
Oh my God.
Yeah. On that note, 2025 is almost over. And what a lovely way to end it.
Yeah,
There's no better way to end it than this way.
The new pants.
The new pants.
Hey,
new pants going into a new year. It's new pants 2026.
You exude confidence, I mean,
Jeremy's going to walk into a room and be like, there comes Jeremy and his new pants.
Get yourself a birthday or a Christmas gift. Get yourself a new pair of pants. All right.
Yeah, it's true. Yeah, I hope everybody out there is having a good holiday season and that you have survived Ramahana Kwanzmas. It's a great season, a beautiful season, a time of endings and renewals. But I'm grateful that all of you have been with us throughout this year on our podcast journey. Your support means everything. So please do not forget that we are here for you, not just in audio form, but in visual form on the YouTubes. Please subscribe to our ASHI HLA YouTube channel. You won't miss a single episode. We are there for you.
Absolutely. And for our listeners who prefer to watch our podcast in a different language, there are captions available on YouTube in several languages.
So cool.
You can find step-by-step instructions. They're in the link in our bio.
Awesome.
All right.
Let's get to it. Let's do today's episode. Today's episode is a spicy one. We like bringing you the spice. It's controversial, maybe for the wrong reasons. Maybe after today, it won't be so controversial anymore. Today, we are talking about antibody-mediated rejection in liver transplantation. So stay tuned. We're going to be right back with Dr. Jacqueline O'Leary, Chief of Hepatology at the Dallas VA Medical Center, and she's going to take us through this whole thing.
Human Immunology is the official journal of the American Society for Histocompatibility and Immunogenetics, published by Elsevier and led by the current editor-in-chief, Professor James Matthew from Northwestern University in Chicago. Since its launch in 1980, Human Immunology has published more than 6,000 articles covering immunogenetics, transplantation, immunology, autoimmunity, and immunity to infectious diseases in humans. The impact of human immunology is evidenced by more than 146,000 citations accrued by the publication, which have been downloaded over 4 million times. Join our community of authors and share your discoveries with a global audience. Visit sciencedirect.com/journal/human-immunology to find out how to submit your research.
Welcome back, everybody. Today on Coffee and Compatibility, we have a topic that I feel like people are not talking about enough. I am so excited to welcome Dr. Jacqueline O'Leary, who is the Chief of Hepatology at Dallas VA Medical Center and Professor of Medicine at UT Southwestern Medical Center. Dr. O'Leary completed her GI and Transplant Hepatology Fellowship at Massachusetts General Hospital and pursued postdoctoral research in immunology at Harvard. Her clinical research has focused on antibody-mediated rejection in liver transplantation. You heard that right, liver transplantation, a critical area that we work to improve outcomes in for our transplant patients all the time. Dr. O'Leary, thank you so much for being with us on the podcast today. May we call you Jackie?
Absolutely. I would love it.
Thank you so much. I am thrilled that you were able to accept our invitation and are with us today, because my laboratory types liver patients and donors. We antibody screen liver patients for DSA, and that is a rare, rare thing. And I think when I say that to people, most folks on the HLA side think we're nuts. But you have published a lot of really poignant work about the potential for antibody-mediated rejection post-liver transplantation. And it's a topic that I feel like HLA isn't very involved in most places, and maybe we need to change that perception. So I can't think of a better expert in this area to talk to about other than you. I think this is great. Can you start by giving our audience a little bit of background about why the perception is out there that liver is so resistant to AMR? Maybe some people take it a little too far and think it's completely resistant to AMR. And tell us about your foundational work that showed maybe we should be giving AMR another look in liver patients.
Great. Well, it's so exciting to be here with you today and kind of maybe give a little background to all of this, because when I was a GI fellow, no one ever talked about it. In fact, there was no teaching at all on antibody-mediated rejection in liver. In fact, I was personally taught that it never happened. And so, one of the things that was exciting is Jorn Klintmom developed this biorepository and decided to open it up for collaborators. And Dr. Terasaki came to us with a proposition to look at antibody-mediated rejection in liver transplant, which got me reading. And I was curious about it. And since, of course, it had been well known and described in essentially every other organ, I thought, of course, it was going to be of importance in liver. It's just that the liver is so large and has such a regenerative capacity that maybe it would take more antibody to take down the liver. And so that's what we started with, looking at the low-hanging fruit of chronic rejection, which of course had been described for a very long time, but the quote-unquote, etiology was quote-unquote unknown, when of course it had been known for chronic rejection in so many other organs. And so the main things why the liver tends to be thought of as more resistant is its size, its regenerative capacity. It actually secretes soluble class 1 antigen, which will bind up the antibody, and then the Kupffer cells eat it. And it can even show C4d positivity within the Kupffer cells, documenting that the liver is protecting itself. And then also remember, constitutively, the liver does not produce class 2, unlike all the other organs. So under a quiescent condition, you can actually have antibodies present, but if you have no target to bind to, then it can not be causing injury at that moment. So I think there are so many reasons why this wasn't discovered for a long time, but all of that has gone away. And we now just know that the liver is more resistant, but it is not completely resistant. And we have definitive criteria for acute AMR in liver published in 2016, codified by Banff, and everyone accepts that. And then proposed chronic AMR criteria, which really probably needs a little bit further adjustment, but we're working on that through Banff, and I think we're going to get to the next step very soon.
Is it, well, you tell me, and forgive me, by the way, if I take furious notes during this entire interview, because I'm going to be learning a tremendous amount as we go along. But is there a difference then between class 1 antibody and class 2 antibody in how they affect the liver?
Yes, absolutely. And so that's what's been so interesting, is that, right peri-transplant, class 1 is what can result in acute AMR right after transplant in very large amounts. The problem is, as you know, that we don't have the world's best way of quantifying antibody, although certainly C1q tends to be better, and dilutions are, of course, probably the best way to go about it, but that's expensive. And so class 1 right up front is probably the most dangerous, but you usually need very high titer or and as well as usually multiple to take down a liver just because it's so large compared to the kidney. However, chronically, what we see is that class 2 really is what causes T cell mediated rejection later, as well as chronic rejection and chronic AMR.
So then, to follow up on that real quick, in your experience, what is enough class 1 antibody, at your center? Is there, for example, a certain MFI that you look for, or a certain titer of antibody that you look for at your center to say this would be too much?
So the problem is that nobody ever has developed cutoffs, but that was one of the originally, like, I was so privileged to get to learn from Dr. Terasaki because our first step really was to look at chronic rejection, which of course we showed that there was a considerable higher prevalence of class 2 antibodies in patients who developed chronic rejection versus those that did not. However, our second step after showing that was to look at unexplained early graft loss, defined as within the 3 months after transplant. And what we showed is that amongst those, there was a certain percentage of patients, and of course, Dr. Dimitris, who did all of the pathology, was able to find so many explained reasons why, of course, we couldn't explain before. But we did find a substantial percentage of people who had actual AMR as a result of high titer multiple targets. The problem is that we don't really have a cutoff, but if it's more than 1 to 3 dilution and there's multiple of them, then you're going to be at higher risk. I think part of the problem with that is that it is so costly to do all of the titering around that, as well as how the prevalence of AMR actually resulting in primary graft non-function is roughly about 2%. So many surgeons won't go after looking for it because they think it's and it is infrequent.
Yeah, I mean, I see that the observation of infrequency sort of alters how we approach this, but I think you're bringing up a really good point that just because it's an infrequent observation doesn't mean it's not an important observation, right? And so I'm curious your thoughts on, is there a particular protocol or method that you sort of think we should be using or would be ideal to use for antibodies? Because you touched on C1q or dilution there, but we know the inherent issues with those two. Is there if you could dream your dream, what would it look like for your patients?
So, I think one of the things that's a problem is that so many surgeons and hepatologists don't do pre-transplant testing. And it's kind of like if you go on a road trip, do you take a map? And the answer is yeah, you actually take a map. And so when people are going into transplant blind based on not knowing what antibodies are present, I feel like they're going on a road trip with no map. And so I really do strongly recommend that everybody at least look pre-transplant to see what kind of antibodies are present. And then when they are present, you want to see if they've resolved after transplant. A lot of the class 1, especially low MFI, less than even 15,000, will completely resolve within even 2 weeks. So, pre-transplant tested followed by post-transplant testing at, a minimum of once at a month, I think would be ideal if it's lower risk. If it's higher risk, of course, you're going to want to do things more frequently. And then I'm, of course, a huge fan of a protocol liver biopsy, DSA testing, and a non-invasive test also like FibroScan to get sort of a comparator to your biopsy so that you can follow it prospectively. I like to know what I'm doing along the way and develop my own non-invasive testing that I can utilize going forward in each one of the patients.
I love this approach, and I feel and I feel so lucky to have colleagues at my center that agree that you have provided through your work, and others have supported that work at other independent centers with independent studies, that AMR is something we need to be looking for in the liver. But with some of our colleagues that have been in the game, especially if they've been in the game for a long time, it is very hard to shift that mindset. I have actually known throughout my career some hepatologists that have been practicing for a long time that have said, hey, stop sending me these emails about you found DSA. Like, just result's your result, and stop sending me the email because I don't feel that's necessary or that I need to know. Basically, I don't care. Right. But then some of my, more contemporary colleagues do want those emails. They do want to know, they do care. So it seems like kind of a generational thing in some ways. And I'm wondering if some of our newer tools out there you feel will help to shift this mindset, like donor-derived cell-free DNA. What do you think about shifting that mindset, but also some of these newer molecular tools that are coming out?
So all good points. I think one of the major problems is that we do not in GI and even transplant hepatology training do any kind of education to the fellows about AMR, making the diagnosis, how to understand HLA testing. And then they come out, they feel like they're supposed to understand this, but they're getting information from you all without that foundation of training. And I think that's something that we can absolutely change. And once we change it and they feel empowered by understanding the information, then you're going to really be able to have an intellectual conversation with your hepatologist. And then everybody's going to be on the same page. So I think that's actually the major barrier. And one of the biggest things that is a problem with the older generation of hepatologists is that because they have no training in it and they have gotten away with it for so long, they feel like they don't have to engage and learn. And even if they try, they feel overwhelmed. And I think that's the problem. Also, the flip side of that is that when people are trying to adjust immunosuppression, we really actually, in this day and age, have an opportunity to personalize immunosuppression in post-liver transplant patients. Unlike kidney and heart and lung, we can go to very low levels, but you need to do it safely with data. It needs to be data-driven, and that's why I love 1 year protocol biopsy, 1 year DSA testing, and 1 year, and I prefer FibroScan just because it's very inexpensive. Once you buy the machine, it's essentially free. And so then, and it measures a lot of things, cellular inflammation, like when you increase the FibroScan KPA, which is the actual readout, it's the stiffness. So that'll be if you have, any kind of antibodies that are causing injury to the endothelial cells, and basically, they have fenestrae, so they close, and so then the stiffness goes up. Also, cellular inflammation will do that as well. So you can use that prospectively after your 1 year protocol biopsy, and you're going to find so much on your 1 year protocol biopsy. And if you don't have DSA and your 1 year protocol biopsy meets the BAMF mini, you can actually go to super subtherapeutic levels of immunosuppression. And so I think by getting that important message out, that with some, not a lot, but some testing, you really are going to personalize immunosuppression, that message will resonate with hepatologists as well.
These are fantastic points. When you said that, I got so jazzed because coincidentally, just last week, our transplant hepatologist reached out to me to ask if I would do a couple educational sessions for their hepatology fellows. So yes. This is great. I'm totally going to shout out. Well, I talked to Jacqueline O'Leary last week and we talked all about this. So this is fantastic. I do think there is such important expertise that needs to be imparted from the HLA lab to the clinical parties. There are even some things that might seem tangential. I was just having a discussion the other week with our transplant pharmacists, and the fact that something that could be really important in pediatric liver transplant recipients is the fact that there is potentially linkage disequilibrium or a linkage between an HLA haplotype. I think it's the same haplotype for narcolepsy. It's DR15, DQ6, that leads to augmentin sensitivity. So
Oh, wow.
if you're giving your PD liver recipients augmentin, this sensitivity could increase liver damage in those patients subsequent to
Wow.
this augmentin, right? And unless you're talking about these things, like who knows? So I think this is like a fantastic point, but I'm super jazzed now, especially now, to get to talk to our hepatology fellows. I agree. I think we really need to do some cross pollination. Clearly from this talk, there's a ton that HLA people need to learn about the liver and what it's capable of and where its limits are too.
If I could just make one point, it's actually not just the hepatology fellows, it's actually the GI fellows as well. Because the GI fellows are the ones when all of our liver patients are bleeding, remember, they're writing the transfusion orders. And I was taught you don't need to leukapheresis, you don't need to have pooled platelets, you don't, all of these things that we really can minimize sensitization of our liver patients. And the GI doctors need to know that as well. It's very simple. Plus, there's a big shift in coagulation in the liver. So we used to think that the patients were hypocoagulable with their INRs being elevated. Then we identified that they were actually rebalanced coagulation because when you have liver dysfunction, you decrease production of protein S and protein C, which then rebalance the coagulation. And now we know when they have acute decompensation, they're actually hypercoagulable. So this is a whole shift in paradigm, and we actually need to be transfusing our patients even less. So it's a huge opportunity for education. It's a huge opportunity to greatly allow better interaction between the HLA lab and GI hepatology community.
Yeah, I mean, I think this is something that's come up across a number of the episodes we've done where there's sort of a gap of knowledge of HLA and the clinician partners there. And so I agree with you. This is an excellent opportunity for us. I do want to kind of go back to the personalized medicine approach that you touched on earlier, because I think it's fascinating to talk about how you can go to the sub levels that you were mentioning and how that relates, or how the HLA labs can better assist in sort of the optimization of the therapies post liver transplant.
Such an important question. So the biggest predictor of weaning failure is HLA DSA class 2 presence. So and so that it's a biomarker, right? It's a biomarker of under immunosuppression and failure of weaning. So it's way better than cell-free DNA, because cell-free DNA, you are going to have an acute injury. The big problem in patients who develop HLA class 2 DSA is that, remember, the liver under quiescent conditions doesn't express a lot of class 2 antigen. So let's say the patient suddenly gets COVID, right? So when you get COVID, then it actually does affect the liver, and you upregulate class 2 in the liver. Or let's say you have adenovirus, same thing. Or let's say you gain 20 pounds and you start to get fatty liver, right? So then you're going to upregulate class 2, and then suddenly you can get binding. And so out of, quote, nowhere, which is not nowhere, then you will start this injury that it had been waiting to occur. But with adequate immunosuppression, which of course is actually different for every liver patient, then you actually, even if you have class 2, you have the ability to make it go away. And if you have fibrosis related to it, it can resolve as well. So it's not just about going down on the immunosuppression. It's about who needs more, who's just right, and who actually needs less.
So many livers are transplanted along with another organ, right? Whether it's a liver kidney or another organ. How does transplanting another organ in combination with the liver affect this whole picture?
Great question. So, I think what happens is that when you have HLA class 1 DSA and you transplant the liver, which they usually put in first, then it will actually secrete the soluble class 1. It will also take the hit for the other organs, so it will bind. Cells will die, and it will regenerate as long as it's not too much. Oftentimes, the surgeons will wait until the cross match, which usually is flow, then will go to negative, and then they put either the kidney, the heart, whatever, in afterwards, and then it is protected. However, what happens is because the liver does not express much class 2, when you have class 2 present, then it doesn't protect the other organ. And so even with the allosen paper, which remember, they did everything by cytotoxic cross-match and showed that when they put this auxiliary liver in, right, the patient didn't actually need a liver, but they put like a half a liver in, and then they put the kidney in afterwards. It was funny because in the paper, if you just read the abstract, it shows that the liver completely protected the kidney. But if you read actually the whole paper, of course, yes, very important, one of the kidneys was quote unquote lost, where the B cell cross match was still positive. Guess what? That was the class 2. And there was another one that did end up with rejection as well, although it wasn't lost right away. So, I think the bottom line is we actually understand this. People say we don't understand this, but we understand this. The liver does a great job of protecting against most class 1, unless it's to the moon, in which case it doesn't. And then it does not protect very well against class 2.
Thank you so much for being with us today and being the springboard for this like bidirectional learning. This is a hugely momentous opportunity for the HLA community to impart this type of knowledge and to learn so much in return. I am so glad that I get to be involved in testing related to liver transplantation, and it sounds like that's only going to grow. If I had a dime for every time I heard somebody say, well, we didn't even used to look at B cells or class 2 results, right? Almost like it's a dismissive thing. But your point is so key. It's so key. That's why we look at it today, and we can. So like, why shouldn't we? Thank you so much for all the work that you're doing and the important work of, if you don't look for it, you won't find it. Right. So thank you so much for that and for joining the podcast. We so appreciate it.
Oh, well, it's been so much fun. Thank you.
Thank
My
you.
goodness.
Thank you so much for being here. Welcome back to Coffee and Compatibility. We are here with the tea. We have a question from a listener, and the question is, I've been working in an HLA lab for about 2 years now, and I'm interested in sitting for the CHT exam, but my institution doesn't cover the cost. Do you all think that taking the exam is worth it?
Yeah.
What do you guys think?
Short version is yes.
Yes. I know it's not required some places, but a lot of places require that to climb a career ladder, as they should. I mean, like after you get a certain amount of experience, you can demonstrate that on the CHT exam. Most institutions, even if they don't require it, I think do give extra compensation for those things. So like you'll get a little pay increase after your next annual eval. So there are lots of like monetary, feel good, fuzzy reasons to do it. It's just a wonderful, it's a wonderful marker that you like really, your stuff.
Yeah, that's how I sort of view it. Is it's one of those like professional hanging on the wall sort of accomplishments, right? That shows that you are a subject matter expert in this particular arena and your own self-gratification. But I wish I could say that everywhere covers or gives monetary gains for having the certification, but I think the real answer is not everyone does. So having having some of those other reasons is of value, but I still think it's an excellent opportunity to sort of put yourself forward and, show your expertise in the area.
Yeah, I will say, I'll put it out there. Maybe it's a challenge to directors out there to support their peeps, or really talk to their C-suites to support their peeps. Our institution will reimburse our folks if they pass. So you have to shell out the money, and then you get reimbursed, and only if you pass. And it is a hard exam. Plenty of folks take it and do not pass the first time. That does not mean that you're not good at what you do. It just means you need, a little bit more foundational knowledge. Don't give up if you don't pass the first time. A lot of people don't. That doesn't mean that you are not meant for this career or that you're not good at what you do. I have a program in our laboratory called First One's Free, where I pay the exam fee for the first exam that folks want to take. So whether it's their CHT or they're ready for their CHS, I would even do it if somebody in our lab were sitting for their director's exam. If they want to take a crack at an exam and money is a barrier, I will fund their taking the exam at least once. To give people, I don't want people to feel like the only reason they don't go for that achievement is a financial barrier. It's worth so much more than that in the long run. So I would challenge directors out there to find more financial support and resources in whatever way you can for your folks. It's worth it for them and for the laboratory.
Well, it also shows, let's say, even in the scenario where HLA is not going to be your entire career, but is going to be a chapter in your career. Even if that was the case, the CHT exam is a fantastic way to demonstrate that while you were in this field, you excelled at it. You achieved a level of expertise, that is really hard to attain. And when you move on to your next chapter, if that's what your plan is, if you were to move on to that next chapter, that would be really impressive on a resume and on a CV. Now, we hope you don't move on and have other move on from HLA. I think HLA is a great way to spend your career, and that being the case, it's a really benchmark level of expertise that is. It sets you apart even as you move around within the HLA community, and opens a lot of doors and opportunities. As you look for promotions and things like that within the HLA community. I also think it's really important that we as a field at the technologist level demonstrate a high level of expertise and competency. Even as you listen to some of the congressional hearings that have gone on recently, they're sometimes looking at level of expertise of people working in this field. And so I think it's really important that we as technologists demonstrate that high level of expertise.
100%. We hope that your next career move is for your CHS and or your director's exam. Shoot for the stars, folks. And on that note, if you need career advice or have a question about something happening in your laboratory, visit our podcast page at ASHI-HLA.org/page/ASHI podcast, or email us at info@ASHI-HLA.org with the TEA in the subject line.
Hey there, Coffee and Compatibility listeners. Do you have a technologist that you'd like to spotlight? Nominate them by sharing their story with us. Email us at info@ashi-hla.org for a chance to feature them in an upcoming episode of Coffee and Compatibility. Don't go anywhere. We'll be back in just a few moments to recap our thoughts on today's episode.
I am so glad that we got to cover this topic. I've been waiting for so long to cover this topic. It makes me like...
We did not know that you were super excited about this.
I'm super excited.
It was awesome though. I learned so much. I'm like, why did I not know all of this about liver transplant?
Yeah, I mean, it's so controversial.
Yeah.
She makes some foundational immunologic points that it shouldn't be controversial, but it's so controversial. It's controversial because if you're not looking for it, you won't find it.
Which is convenient. in some cases,
Right.
but not in liver transplantation, I have to imagine.
Right. So I do want to point out to our listeners that this topic is just so fascinating that we were talking with Dr. O'Leary after the recording stopped, and she made an even better point. I asked her, you know, do you think if more people were looking, if more centers were routinely post-transplant monitoring their liver transplant patients for AMR and development of de novo DSA, that the incidence would be higher than 2%? And she said, I don't know if it would be higher than 2%, which is really estimating like full liver failure, like they need a second transplant, full liver failure. She said what she does think would be much higher is that most fibrosis, in her estimation, is probably caused by HLA donor-specific antibodies. So all these secondary issues that you see that are inflammatory, very likely for a lot of patients have an antibody damage component. And she thinks that those numbers would be so much higher. And obviously, like, preventative for issues if more people were looking. And I agree. This is a brilliant point.
So it seems like this podcast episode needs to be required listening for hepatology fellows, maybe, is what I'm picking up from this.
Oh yeah, I'm going to give it
Yes.
out. The second this is live on YouTube, I'm going to into that lecture that I have to give, which I think is in February, maybe. I'm going to slide this right in there. I happen to co-host a podcast and here. Just listen to that.
Extra credit.
Right.
Yeah, shameless promotion.
Yeah, no, I thought she did a great job of covering everything from, you know, why there's these misconceptions to where we're going and how that. So it was great. All right, guys.
I love the part really quick before we go, because I just can't solidify it enough. I love the part where she reminds us that it's not just that the liver's protective mechanisms are so potent for class 1, but also the lack of initial expression of class 2 that it gives people the wrong impression about what's possible. So important. There is class 2 expression in the liver, but later, after inflammation, after significant inflammation.
You got to kind of poke the bear.
You got to poke that bear, that liver bear.
Exactly. Until next time, guys. Bye.